let's see. So with that, we're actually going to, here's just a brief overview of the agenda. But first, while you're settling in, I did just want to pause and have you all reflect on why you're joining today. I think, we've been in a virtual era for years now. We have webinars on repeat, et cetera. So I do want to just take a mindful moment. When did you get this invitation? Why did you register? So we're already well into the workday, but some of us might be front and center tuning in, pen to paper, taking notes. Others might have this on in the background. And regardless of who you are in this situation, I hope that everyone can walk away knowing more about HepNET, but also the TA that's available and how we can support your harm reduction and viral hepatitis programs. So you can see the agenda on the slides. I do want to do just a bit of housekeeping real quick. We do want the space to foster a sense of community. It's semi-structured, semi-informal, flowy. This is an event where we encourage the use of webcams. So if you'd like, you can come as you are, turn them on. If not, it's totally up to you. Everybody is muted right now, so you can feel free to use the chat box. There's an option to raise a virtual hand if you have questions or comments. This is being recorded, so the recording and the slides will be circulated after the event. And we are going to allow a few minutes at the end just for a short evaluation. So we definitely appreciate your feedback. Just to note from our last evaluation from the HepNET Town Hall in May, we heard from a handful of members that they wish there could have been more time for discussion. So loud and clear, today we actually have about 25 minutes that's solely dedicated for moderated discussion. Next slide here. For folks that aren't familiar with HepNET, I just wanted to provide a brief overview. HepNET is the acronym for Hepatitis Network for Education and Testing, providing technical assistance and training to network members with the focus on hepatitis B and hepatitis C to identify and address the unmet needs of people who inject drugs. You can see the logos below here. We do have a partnership team that's comprised of NASTAD, NVHR, and NACCHO. Each of our organizations have existing networks and coalitions that expand beyond the reach of the viral hepatitis community. So our partnership team, between the three of us, we're uniquely positioned to expand our existing platforms and integrate viral hepatitis and injection drug use with all of our public health priorities. I am going to include some links here in the chat box. We have a HepNET website you can take a look at. It includes our mission, our vision, promotes upcoming and archived events. We also have the HepNET one-pager, props to Cass from NVHR. That's included in the chat box. So everyone can take a look, and use for future reference or share out with others as needed. We do have a handful of folks that I can see on the call who are already network members. But if you're not and you're interested in becoming one, totally free, no strings attached. The sign-on form is available. Included in the chat box. Thank you, Zakia. And we're going to make sure that you're in the know about HepNET everything. So I think lastly here, you'll see the infographic to the right. It's this like visual here with network members, etc. So I just kind of wanted to paint a picture that we have HepNET, which is comprised of network members like yourselves, 2 training consultants who are actually joining us on the call today, Nick Boyle and Tina Reynolds. They're subject matter experts who have already developed a curriculum for our LLE consultants, which are leading with lived experience folks. And they will provide TA to learning communities who are network members. It starts as a small group of participants. They're put into cohorts. They participate in goal-based and topic-specific activities with the aim of reducing inequities in viral hepatitis and care among people who inject drugs. So I see some intros already coming through. Let's get this party started. Tell us about who you are, and in the chat box, if you could share your name, if you're affiliated with an organization, and then where you're joining from. I'm Jasmine West, she, her pronouns. I'm a manager in NASTAD's hepatitis team, and I'm joining from DC. And I'm actually going to pass it over to Bwatma for her own introduction, and then to elaborate a bit more on today's event.
Hi, everyone. For those of you who are on the East Coast, thank you so much for sticking with us. I know it's later in your workday, so appreciate that you all took the time to join us. And for those of you who are across all the other time zones, same, because we know that everyone's working really hard. And I just want to take a brief moment to acknowledge that we are leading into World Hepatitis Day, which is a time that we celebrate, but we also celebrate with caution, because we know we have a long ways to go in terms of addressing our global viral hepatitis epidemic. And so really do want to acknowledge and thank you all for the work that you're doing and the contribution that it's making towards eliminating viral hepatitis globally and not just nationally. So with that, I'll just say really quickly, as you've heard from Jasmine, HepNET is designed to be responsive to the technical assistance needs of our members. But we're also very much about establishing community and figuring out the types of supports that are needed to improve viral hepatitis outcomes for people who use drugs. And something that we've talked about a lot, and something that we really wanted to highlight with today's webinar, is that our coalition is one coalition. We are one set of partners that exists in a vast community of health departments, CBOs, clinics, SSPs and other harm reduction settings and substance use treatment settings, just to name a few partners who are critical to doing this work. So as part of our networking for HepNET, what we really wanted to be able to do today is to focus on our partners, our broader partners who are working on opportunities to provide national and state focused organizations, as well as local organizations, tribal organizations, technical assistance and capacity building to really be able to enhance your work both programmatically and policy-wise. And know that you have true experts on the line. We know many of you are experts as well. We also plan to present future events to highlight our partners throughout the country who are doing work that we know is really critical to our membership within HepNET. So an ask that we have of you today is to actually let us know if you have recommendations of other folks who may or may not be a part of HepNET, who we should highlight because of the types of technical assistance and capacity building that they're providing. We also want to ask you to listen closely to each of our presenters with an ear for how they might support your work and your program. And as Jasmine mentioned, you're going to have an opportunity to engage with them. So really think about the questions, concerns, any barriers that you might have had in connecting with them so that we can name that and work on it today. So with that, I think I'm passing things off to Mark Perino, Director of the American Association for the Treatment of Opioid Dependence. But I also want to say a huge thank you to all of our speakers today.
So thanks very much for the opportunity to be with you. The American Association for the Treatment of Opioid Dependence represents the opioid treatment programs, formerly known as methadone treatment programs, in the United States. We're organized through 29 chapters and other individual members, representing just over 1,300 of the 1,900 OTPs in the country. There are about 600,000 patients in treatment at the present time. And I can tell you that the leading drug that we are now treating is fentanyl, which should be of little surprise to anybody. 80% of newly admitted patients in our programs are using fentanyl, whether they know it or not, but that's what the toxicology samples inform us as we engage in treatment and as we begin the induction for the patients. I can tell you that clinically, the induction is much more difficult with fentanyl as compared to heroin or prescription opioids. That's because of the potency of the drug. And there are some strange metabolites in fentanyl as well. It's not a pharmaceutical product outside of the fentanyl that is produced for legal use in the United States. I'm speaking about illicit fentanyl. Also add to the clinical complexity is a lot of these folks are using methamphetamine. It's a deadly combination. And we found that in order to achieve stability clinically, we have to increase the doses of methadone past 120 milligrams, which used to be considered more of the upper range of therapeutic daily doses. Now, achieving therapeutic stability with methadone is about 160 to 180 milligrams. The model of the opiate treatment programs has been more comprehensive care, which has always brought us into the realm of treating HIV infection, working with partners in doing so, and certainly hepatitis C and more currently hepatitis B. And I can tell you that the membership of AATOD is on a continuum of care. And this also involves coordination at municipal and state health department levels as well. A good part of our work, aside from the domestic OTP providers, is our membership with the World Federation for the Treatment of Opioid Dependence. My counterpart, Dr. Ikaro Manimani in Italy, is my counterpart who organizes the providers in the European sphere. But we do work together, especially when it comes to the United Nations Office on Drugs and Crime and the World Health Organization. What I can tell you is that a good part of our work deals with federal and state policy partners, and there have been major changes, especially during the period of COVID-19, when OTPs, like the rest of healthcare, had to adapt to a series of new features. And while OTPs, which are heavily regulated at the federal and state level, have been conservative in providing take-home medication, we have learned incredible lessons during the period of COVID-19, where we can be certainly much more liberal in how we provide take-home, and we want to help the patients transition to care that is less onerous as we get past COVID-19, which hopefully will be soon. Our interest in working with hepatitis C dates back 20 years ago, when we were working with Sue and Denny Simon of the New Jersey Hepatitis Association. They were tremendously helpful with their associates in developing a training manual so we could engage OTP administrators and clinicians in working to treat hepatitis C in addition to treating opioid use disorder. So the primary reason OTPs came into existence in the mid-1960s really was to treat opioid use, at that time heroin, which was the dominant drug of use. That would morph into providing services that would wrap around the use of medication. Now, there are 3 federally approved medications to treat opioid use disorder in the United States by the Food and Drug Administration. The medication that's primarily used in the OTPs is methadone in about 80% of our patient population, followed by buprenorphine. This is the case based on the nature of the patient we're treating. As I said, mostly at the present time, it's fentanyl, but also heroin. There's been much less prescription opioid use on admission as compared to what was the case 15 years ago. What I also can tell you is that we began to train with the SAMHSA grant clinicians throughout the country on how to best treat hepatitis C in our patient population. And as you can imagine, it's significant given the fact that we're primarily treating injecting drug users. And we also started doing surveys 15 years ago among the OTP programs. And we found significant variation in how a program would test or treat hepatitis, whether that would be done at the program site or through referral and coordination with other service delivery systems. Generally, we found that the questions of third-party reimbursement, which could be confusing at times, especially when you're dealing with Medicaid, because it's a state program rather than a federal one, would create various challenges. So that had to become something that the programs would deal with on a case-by-case basis. When we worked with CMS Medicare and they implemented the first ever Medicare reimbursement rate for OTPs, which went into effect on January 1 of 2020, we had successfully worked to incorporate hepatitis C treatment and testing as part of the reimbursement paradigm. And this is a tremendously helpful sort of issue to manage. So we now currently work with the addiction technology transfer centers otherwise known as the ATTCs, in continuing to do hepatitis training. We work with the ATTC networking office as well. In addition, to demonstrate our commitment in treating and responding to the needs of our patients, we also have an assigned staff member who I suspect will continue to work with you in the future. And I've mentioned this to Jasmine as well, Carlene Maxwell Taylor, who, as one of her major domains of responsibility, is working to treat hepatitis C and B within the OTP structure. So it is part and parcel of the focus of how OTPs treat patients, which is holistically. And even if there are programs that don't want to offer as much holistic care as we think the patient should get, there are federal and state regulatory structures and through accreditation survey instruments that really do focus on what the OTP is doing and how we are treating our patients. So it's a comprehensive program. There are 1,900 at the present time, which is 400 more treatment programs than existed in 2015. So programs are expanding. In this next phase of expansion, we have worked with the Drug Enforcement Administration to develop what are called mobile van units that work under the aegis of the OTP. Mobile van units were approved a year ago, and at the present time, a number of states, especially New York, New Jersey, the New England area, which is now going through a major expansion of these mobile units, which basically extend the reach of the OTPs into rural and suburban communities in the United States. And SAMHSA has also, the Substance Abuse and Mental Health Services Administration, has increased the opportunity to provide treatment, again, as hub sites, spokes to the OTPs. And these are the formerly known satellite medication units. Once again, SAMHSA has recently redefined the elements of service that we can provide, and we will also extend access to care. And finally, we have a major initiative to increase access to medication-assisted treatment through correctional facilities. Currently, we're working with associates in Rhode Island and Connecticut, in other states, certainly within the structure of AATOD. But New York State passed remarkable legislation, which would now ensure that all correctional facilities in New York State are going to provide access to medication-assisted treatment for opioid use disorder. And the New York State Office of Alcoholism and Substance Abuse Services, in addition to our provider colleagues in New York State, are now in the stages of implementing that. And we expect that that kind of example will be followed by a number of states. So one of our long-term ambitions has been to be sure that individuals with opioid use disorder who are in correctional environments will get access to treatment and then transition away as they are released from confinement and come back to a community-based setting. We can tell you from the preliminary research that's been done so far that when these programs set up and have this warm handoff to the outpatient services, that there's a better than 54% reduction in recidivism and better than a 50% reduction in post-release mortality. So that's my sort of brief sketch, giving you an overview of the OTPs, what we've done to expand access to care, and also to get into making sure that the patients get the services they need, including hepatitis C and B. And obviously, we will continue to work with you guys as time proceeds. So thanks again, Jasmine, for this opportunity, and I hope this has been useful to you.
Thanks for that, Mark. I think that, yeah, there might be some questions during the open discussion. So if folks have them, you can save them for open discussion, or you can chime in the chat box. We are going to turn it over to Mike. So all you.
Great.
And
Can I get
Mike,
a thumbs up if you're seeing slides?
Seeing slides, and if you wouldn't
Sorry.
mind a self-intro.
Of course. Hello, everybody. My name is Mike Selleck. I'm the Associate Director of Capacity Building for the National Harm Reduction Coalition. The reason I was asked to be here, and thank you, NASTAD, and for inviting me, and everybody else for showing up. I've been at National Harm Reduction Coalition for almost 7 years now, and the first 5 of those years I was focused solely on hepatitis C work. I was part of a group of people who helped to get the hepatitis C elimination plan created and put into and implemented in New York State. I'm also part of End Overdose New York with Vocal New York and Drug Policy Alliance and a bunch of other groups that passed that law requiring MOUD to be available in all carceral settings in New York State that Mark was just referencing. So I'm glad to hear that's starting to really go into effect and make differences. I've been working in harm reduction for over a decade now. My first starts were in the South Bronx and East Harlem, where I worked in services and peer training. And I currently live in Burlington, Vermont, and am trying to get similar efforts around ending overdoses and hepatitis C here in Vermont. That's a little bit about me. So if you haven't heard of us, National Harm Reduction Coalition, we've been around for 26 years. We do policy advocacy work around Hep C elimination, overdose prevention, just getting syringe access into the whole country. We also have conferences. I'm going to show you a slide about that in about 30 seconds. Today, I'm mostly here to talk about our trainings and technical assistance. We do overdose prevention, and we have tons of resources and publications. Go to our website, easy to remember, harmreduction.org. That's also where you can reach out to us, ask for trainings or other technical assistance. We also work on some CDC trainings with NASTAD, NHRC, and a bunch of other groups. So here's the slide I referenced about our conference. It's coming up. It was supposed to be in Puerto Rico in 2020, but was canceled for very obvious reasons. But we're going ahead with it now, October 13th through 16th in San Juan, Puerto Rico. I hope that people have a chance to go. You can email any questions you have to conference@harmreduction.org, or if you go to conference.harmreduction.org, you can figure out where to register, other information about it, whatever you need, you can find out what you need from these 2 places. It's a great conference. It's all abstract driven. Unfortunately, all the abstracts are in and people should have already heard whether or not they're speaking. But what I love about it being abstract driven is it means it's different every single time. It's not the same speakers saying the same thing. It could be anyone on this call if you write an abstract and you get accepted, but not this time around. You're going to have to wait 2 more years. We do it every other year. So here's just some quick titles of our hepatitis C trainings that I've worked with people to write and provide over the years. We do Hep C Basics, Medical Care and Treatment Update. I'm very happy with our Hep C Prevention for LGB and PGMC+ individuals and communities. I think this is a really underserved community that we need to be doing more work with. It's probably, like, I think, the 3rd highest new infections for hepatitis C, yet I don't see very many programs that are providing services to LGB, PGMC+ communities actually talking about hepatitis C. I would love to see navigators involved in those programs. So if that's something you're interested in starting, would love to help with technical assistance for that. We also do conversations around the MOUD as HIV and Hep C prevention, and tons of other trainings related to that. We also have tons of other harm reduction trainings. Like I said, we've been doing this for 26 years. I got a bunch of them listed out here. My favorite one to provide is safer injection and wound care, which is also very good for Hep C prevention. I'm not going to go through all of these, but I just thought I'd all put them on the slide because it's a pretty thing to look at and can give you some ideas. Like I said, we've got way more than the 8 in front of you. So if you reach out to us looking for training, Hep C related or otherwise related, our focus is on, any sort of drug use, HIV, Hep C prevention. You can reach out through our website or you can reach out through the CDC, and we would be very happy to work with you and set up trainings or technical assistance. One thing I really want to touch on today in my limited time was talking about the hepatitis C navigation in the New York City syringe service programs. We've been partnering with the New York City DOHMH since 2014 to supervise or train and support peer workers. We have 2 peer workers at every single syringe program in New York City, which comes out to about 32 people. And a lot of them have patient navigators as well. We work with all of these people so that they have the best knowledge of Hep C, know how to do testing. We provide career support for them, counseling support. Like if you're a peer worker in New York City, reach out to us and we can help you become a credentialed peer worker, work on your resume, deal with struggles if you're new to this industry. So that's something that I ran for the first 4 years I worked here, and now my coworker Jose Martinez has taken over for the last few years and is doing an amazing job. We also have done some work to talk more about overdose prevention with the same navigators. And here's just some data about the work we've specifically been doing. We've trained 111 syringe service program participants and had helped them get employed as hepatitis C peer navigators We've trained 58 patient navigators who are now employed at health centers and hospitals and community organizations. I think this is really important work, and I would love to see this happening in other cities and states. It's not that challenging to start peer training programs. We would love to partner with you. We can do training of the trainers to teach you, your staff, how to do the trainings we're doing and how to better supervise and support people who use drugs or people with a history of drug use. Usually talk a lot about the principles of harm reduction, but I know I'm at the end of the time on this thing, so I want to make sure I speed through it. So here are some harm reduction services, another good slide to look at, but I think I'm going to leave it there and I can answer any more questions. Harmreduction.org, that's where you go to ask for TA or for trainings. Like I said, we have plenty more things that aren't listed here. We also have online modules, recorded webinars, plenty of resources and stuff to check out on our website, or reach out through the training tab on our website and we can schedule something to either provide technical assistance or trainings directly to your team. Thank you very much.
Thanks, Mike. That's a lot in 10 minutes. I know you could talk about the resources that y'all have for a whole hour. So to his point, definitely lots to be offered and to check out. I think too, just for, I threw in the chat that HepNET will be represented at the National Harm Reduction Conference in October. So NVHR and NACCHO will be there to put on the session. So whoever's joining, let's all connect so we can see some familiar and friendly faces at the conference. But with that, Nick and Tina, I will hand it over to you.
Thank you very much. How much time do we have? My name is Nick Boyle. My name is Nick Boyles, and I am the executive director at the Indiana Recovery Alliance and the Hep C liaison at Urban Survivors Union. And Tina, did you want to introduce yourself before we start in?
Sure, I'd like to. Thank you so much. We're glad you're here this afternoon. My name is Tina Reynolds. I am the Director of Equity and Inclusion at North Carolina Survivors Union, and I'm happy to be here and happy to be working with Nick on developing this training manual.
That's probably the best part of it. I'm going to share my screen for a brief period, and then we'll let Tina get into the gooey stuff, the nuts and bolts. Just 1 second. So when we thought about this, we decided we wanted to break it up into some basic modules and talk about stuff maybe some people weren't up to date on. So we started first, or maybe we want to get a litmus test first. So when we started about an intro into what HepNET was. Tina will start with the commitments and agreements and a getting related exercise. Those are actually something that we found in our circles have been really powerful and have created a camaraderie and kind of just a meeting place in the middle. Then we'll go quickly into the ABCs of viral hepatitis. And as you can see, they'll be broken up into different parts what we'll teach in that particular module. We'll then go in, I'm trying to keep this quick, you guys. Then we'll go into harm reduction and viral hepatitis. We'll talk about that. We'll talk about what, Tina will talk about what it looks like to create a positive drug culture in the Black community. Then we'll move through power, through experience. So at this point, we've given them ABCs of everyone. What is hepatitis? What does it do? What is the terminology? What are the words? Why is Hep B so important to get out there, to get education out there about? We'll get through why harm reduction and viral hepatitis are such close quarters and where they intersect and where they can better intersect. And then we move into making them, into letting them empower themselves through our guidance if possible. You know, so we'll talk about the power in your story, busting internal biases, anonymous bias stories. We'll get into like changing your narrative and the public narrative. We'll then talk into one of the most important parts, which is talking to providers and professionals, right? So we need to make sure that they're learning where the soft points are and where the hard points are. You know, talk about working with different health departments, talking about the disparities in medicine, Hep C, and the most marginalized people who have to find a cure in a really hard insurance world that doesn't really care for them, especially people who use drugs. And then what we'll do is we'll sort them into something that's, you know, area specific for them. And we'll talk about how they can take all this that they've learned and start this process in their area, you know, and at the end of it, hopefully what they will have what they will learn is that they have, the knowledge and experience to advocate for both themselves and their peers. We don't have much time, so I'm going to let Tina go through the special part of our training real quick, and then we'll talk again about something else.
Thanks, Nick. So one of the things that I thought about in beginning to develop this manual with Nick was nothing about us without us. And we know that this guideline is how we have approached our training because it's specific to inclusion. And when we think about inclusion, we want to think about it from a perspective of taking in everyone's particular situation, because everyone has had experiences with the health system that have not been the best, especially people of color. And so instead of listening to a training where the issues around viral hepatitis is set into a box that may come later, we're including the issues that impact people of color throughout our training. And we're including it from a perspective of relatedness, right? So we want to offer this training from a perspective of how do we get related, working with systems people, hearing about the expertise and honoring the expertise of people who use drugs and people with lived experience. And this is very important. Language is very important. So we are processing, we're preparing to walk people through the process from a very organic perspective, where they often haven't been exposed or have the space to create a learning experience of their own, getting related with systems folks. Their experience is very much appreciated. And how do we take that experience and really see people as their value? So the purpose of this is to actually bring about leadership within people who are leaders already, and really honor their experience and their leadership in working with folks who have lived experience, their comrades and systems folks, and bring that nothing about us without us guideline to policy change. And so with this effort that Nick and I are taking on, we are in practice within NCSU with nothing about us without us. And we lead from that place. And we have many trainings within NCSU and USU. We collaborate with other affiliate organizations. And Nick is proudly one of our organizations that come with us on our staff trainings and offer many experiences and or information and trainings for USU and NCSU staff and team members. And so we practice what we preach. And we are developing a letter that we're sending out to honor people with lived experience, to pay people with lived experience. And so we think that this training will actually give folks an opportunity to expand, right? And this manual will give folks an opportunity who have lived experience to begin a conversation that brings them from a place of their experience to a place of knowledge in who they are with their experience. So I think that's it, Nick, if there's anything else.
No, thank you. I know we only have a minute left, so I'll be quick. We have been working. Oh, you're great, Tina. Come on. We've been working on this for a long time with not just USU, but with a lot of people. I don't know if you guys know what Urban Survivors Union is, but it's the National Drug User Voice. And both me and Tina and a bunch of wonderful people you probably know are a part of it. And we got together and decided that there was a gap and a need that we had not been able to address anywhere. So rather than make it just simple talk, just simply talk about it, we put out a PSA that we'll be putting out soon. I'll try and leave the link in the chat for you. The idea of USU and team-based systems and their flattened hierarchy and everything is probably one of the reasons I'm able to do anything that I'm able to do. There are all these people who use drugs who are giving me the best and brightest information I could have. So I know I went over time here, so I'm going to stop before I crash here and do too far over time.
Thanks, Nick. Real quick, I just wanted to make sure that webinar attendees knew that the training that Nick and Tina were going over in the beginning is the training that our Leading with Lived Experience consultants are going to take in order to provide the technical assistance of HepNET, like that HepNET is offering during the learning communities. So I just wanted to make sure everyone was aware that that's the TA that's going to be provided. Those folks are getting trained by Nick and Tina.
Thank you, Cass.
Awesome. Thanks so much, Cass. I think at this point, we will move into the Q&A portion of today's presentation. Thanks to everyone who has listened in thus far, and to our wonderful speakers and sharing your experiences and the services that your respective organizations provide. We're going to do a little bit of moderated Q&A. I have some questions that I'd like each of you to answer, but I'd also like to open it up to the audience for any questions that you all may have. So if you would like to pop those questions in the chat, please feel free to do that now. You're also welcome to unmute and ask your question aloud, but I'm just going to kick things off. So as folks are thinking of your questions for our presenters, I'm going to start with just a very general question. We heard about a number of resources, trainings, collaborations that each of your organization has been involved in. And so I want to make sure that folks on the webinar walk away with a clear understanding about who is the intended audience for each of your services, right? So the question that I'd like each of you to answer is, who is the audience for your technical assistance? Mark, I heard you mention OTPs. There was also a mention of correctional facilities. Mike, I heard a lot of discussion around community-based organizations and peer workers. Nick and Tina talked about people with lived experience. So I just want to make sure that folks have clear who the intended audiences are, and maybe it's broader than those categories that I've mentioned. So Mark, I'll come to you first. Who's the intended audience for AATOD's technical assistance?
Generally speaking, it's the OTPs themselves, because that's who we respond to in terms of clinical and treatment needs and policy development. But also it's working with drug court judges. It's working with people in corrections to expand knowledge of what the treatment is and is not, and also to a number of state policymakers also to explain what we're doing and the importance of treating people with increasing flexibility. So those are, I mean, our target audiences are fairly broad, but that really is the central focal point.
Mm-hmm. Thanks, Mark. Mike, I'll come to you next.
I'll tell you my favorite people to train are people who work in harm reduction. That would be like most of the intended audience of this, but that's certainly not the only people. We do a lot of work with local health departments, like FQHCs, other clinics. Basically anyone who's going to interface with a syringe program. You don't necessarily have to actually give out needles, but I got into this work by giving out needles. I think everyone should give out needles. I think it's the best and most important work we could be doing. So I prefer to be working either directly with people who use drugs or people who spend all day working with people who use drugs, but also health departments, basically anyone who works on HIV, drugs, or Hep C who could benefit from learning a little bit better about how to treat people who use drugs with dignity and respect, and how to use a harm reduction approach. That's what we're here to teach you about.
Awesome, thank you so much. Nick and Tina, I know we talked about a couple of different things during your presentation. One was the forthcoming HepNET technical assistance that you'll be providing to people with lived experience. And then Nick, I know that you also mentioned Urban Survivors Union. So who's the intended audience for those groups? Are they different? Are they the same? We've heard a lot about people with lived experience. So would you like to elaborate on that?
Sure. The focus of our training is for those with lived experience to lead a conversation and include systems folks, and how to actually work with people with lived experience. And specifically what we're doing with this training is including embedding equity and inclusion. So recognizing the disparities, the power people have, and how to shape it, how to shape out a specific strategy, and to be able to establish relationships with systems folks and representatives from a leading perspective, right? Where folks who had the experience can offer suggestions and policy suggestions and and collaborate with many of these system folks to make change. Nick?
Thank you, Tina. Yeah, I mean, the thing is, I think 90% of all of everything I say is hopefully given to people who use drugs, or to people who can help people who use drugs. I think Mike said it really distinctly, especially working in the field. I don't think there's a replacement for it. I think if we're not forward-facing, putting the drug user in the most empowered position and ensuring that we give them not just a place at our table, but inviting them not just to eat with us, but to cook the food as well, then I think we're falling short. And I think we look at things like, I'm going to jump off this pedestal really quick because I'll talk for hours about it. But I think the power of USU and the power of what we do is that there are a whole bunch of people with expertise that's been honed over years that are willing to step in at different places and prove that expertise and show it. So intended audience for me during this HepNET thing will be the people that we can find that want to be helped. You know what I mean? That are not just going there to get a buck, or not just going there to this, but really want to be empowered and want to create a situation for themselves to take whatever me and Tina can give and make a better, be a better advocate because of it, or become an advocate because of it. At USU, our target is any goddamn person that will listen to us. Like we are done playing a backseat to just talking to other drug users. We did that. We tried to ask for help and no one came. So I think at this point, we're just trying to see how we can stay. I shouldn't say no one came. A lot of you guys came, but the people that in power that should have came didn't come. So, yeah, so those are my two intended audiences.
Awesome. Thanks so much, Nick and Tina. So it sounds like if you're a person with lived experience, or you work with people with lived experience and they want to get more involved in advocacy, Nick and Tina are your people to go to, right? To help them feel empowered and to meaningfully engage in advocacy work. If you're an opioid treatment program, Mark is the person that you should be thinking about, and you're wanting to expand hepatitis C services or other viral hepatitis services in your opioid treatment program, Mark can help connect you to additional folks who can help you do that. And then lastly, if you're a community-based organization, a harm reduction program, but even a health department, if you're an organization that's working with harm reduction programs, then Mike is the person that you should be reaching out to. And certainly we'll make sure that everyone has contact information for each of our presenters before you leave today's call. Moving on to another question from the audience. A question has come in from Cass, and this is for Nick and Tina. If organizations are looking for consultants who have lived experience to provide technical assistance on their initiatives from the perspective of directly impacted people, is Urban Survivors Union an organization they can go to with that kind of request?
Absolutely, Cass. As you well know, there's so many intersecting fields, so many places that intersect with drug use. Sometimes it might be housing. You need expertise in housing with people who use drugs. Yes, you can get them from all of our from many people in USU. I always think of it as like the directory, like the phone book for harm reduction. If I need somebody in Detroit who can understand LGBTQ issues as well as far right, organizations trying to move in and pony out people out of neighborhoods, there's someone there. It's that esoteric, it's that that laser focused. If I need someone to talk about methadone reform, like getting these methadone patients to be able to go to a doctor with a prescription instead of having to go to OTP, like having a choice between the two is what I mean, then I can go to a whole entire methadone team at USU. So yes, there's just about everything you can think of that intersections harm reduction or drug use can be found at the USU family or affiliates.
Awesome. Thanks so much, Nick. The next question that came through the chat is, and maybe Mark, I'll start by having you answer this question, and certainly I think any of you could comment on this, but what's on the horizon as far as medications for opioid use disorder and stimulant users? Mark, you mentioned, I believe, that we're seeing a growing number of people using methamphetamine. Is there any insight that you can share around what's on the horizon around medication for people who use methamphetamine or people who use cocaine?
Well, that's been a sort of NIDA long-term research initiative for many years. And while there are different research groups, both at Columbia and elsewhere, that have tried to find a sort of methadone buprenorphine medication treatment for stimulants, it's proved completely elusive. And so it doesn't exist at the present time. Clearly, with the increased use of stimulants like methamphetamine, the hope is there will be a laboratory that will be able to synthesize a medication that will be useful for treatment. It is being evaluated by NIDA, and it's clearly a priority and has been a priority for NIDA. As I said, that kind of medication is elusive and has not been discovered yet. But it still needs to be treated as best as possible. And I think that also with medications, I anticipate that there are going to be a continued number of regulatory changes affecting how medications are used to treat this disorder. And I think some of those issues will expand access to care in different settings. And there are many nuances to this. I mean, there are long-term skilled nursing facilities that don't really foster the treatment of opioid use disorder. And this is a really nettlesome problem. And so that's why we're working with federal and state agencies to try to open those doors. And even though skilled nursing facilities more under the auspices of state health departments, it's still something that has to be addressed. And frankly, dealing with state Medicaid authorities is yet another change. So I am mindful of the fact that as we expand access to care, the issue here is going to be listening to what patients need. If I learned anything as a clinician in an OTP in the early 1970s and later as an administrator, probably the most important thing is you pay attention to what the patient explains, what they think, and what they need. And what I used to say to the staff of the program consistently is, we are guides to the patient. The recovery is theirs. We really prefer, we just offer guideposts. What we're not supposed to be doing ever is providing judgment, because the judgments very frequently are wrong. And as I used to say to the staff, sometimes to their degree of irritation, is we're not always right, they're not always wrong. And that's where we meet in the middle wherever we can. So I think there's going to be a great opening. I see more acceptance on how medications are used. And we have urged federal authorities that there needs to be a massive education and training initiative because the American people do not really understand what we're talking about. And that has to be sustained over the course of many years. And absolutely, the patient's voice is critical in shaping those messages.
Thanks so much, Mark. I want to maybe stay on this point about stimulant use for just a little bit longer and ask Mike, Tina, and Nick if you all have any thoughts on this question. And Mike, specifically, I'm curious, has National Harm Reduction Coalition been receiving any TA requests around this topic? And are there currently any resources that you can provide specifically for guiding community-based organizations, health departments, et cetera, around people who use stimulants?
I don't have anything around MOUD for stimulants, unfortunately, although most ADHD medications are a fine substitute that not necessarily FDA approved or available for people for that use. We have some trainings on stimulants, happy to provide TA on it. Really big fan of our Stimulants 101 training that goes through cocaine, crack, crystal meth, and ADHD medications, talks about like HIV, Hep C prevention while using them, safer injecting, safer smoking. We're in the process of trying to turn that into an interactive online module, but I don't have a date I can promise it. So stay tuned to our website for that, but we happily provide it to any organization requesting if you reach out to us through our website, go to the training tab or just training@harmreduction.org. You can email us directly. And we can also do other TA around that stuff, but mostly that's what we do is provide trainings on how to talk to people about it, how it works on your brain, that kind of stuff.
Awesome. Thanks, Mike. Nick and Tina, any resources from USU around stimulant use?
Tina, you want me to go or you got?
Yes, go ahead, Nick.
Okay. So we've looked into a bunch of this and we've seen some doctors using things like Vyvanse and Adderall as kind of MAT for stimulant use. None of it's really working that well. There were some trials with modafinil, but it's really hard and you have to get the doses and the dangerous levels for people for it to actually work. And so that's the big scare. Modafinil is a drug they used to be called Novigil or Provigil that they gave to fighter pilots to stop narcolepsy or getting drowsy. Has a little bit less edgy effect. It feels wonderful, but like there's not enough to hold from the rush through, you know? So I think until we start thinking about long acting, I think we treat them like shit. You know, we don't look at stimulant users or how to treat them. You know, we're just kind of hoping that because the whole thing of like, oh, you don't have a physical withdrawal. I think a lot of people just kind of say, oh, they'll be okay. So it's just really hard. It's in a position where, you know, like, so for instance, with cocaine in a street setting, if someone was over amping, I give them a fucking benzo or something. You know what I mean? Like I can't prescribe that, you know, and I can't tell that. And some people are studying other benzodiazepines in connection with bringing people down from overamping, but we have a much different drug now, you know? I mean, as you can ask Mike, the drug combination, the drug makeup is different now, you know? And the amphetamines that we're seeing are like more akin to ice than they are to actual what we know as methamphetamines. So I mean, there's some strides being made here and there. KPWID and Vandu would probably know more than anybody because they're doing better work in that area. But there are people trying in little places here. They're just vastly not enough.
Mm-hmm. Thanks, Nick. So it sounds like this is certainly an area of opportunity for future, and we may end up seeing more technical assistance requests around stimulant use in the near future, but definitely some opportunity there. Mark, I want to circle back to you quickly. You mentioned the AATD network and working with them to develop this guide about integrating hepatitis C services into opioid treatment programs. I'm going to drop a link to that guide in the chat, but I was curious if you'd like to say anything more about what the guide contains and how it might help folks that are looking to integrate these services.
Well, I mean, from the point of view of the OTPs, this has to be a sort of constant sort of method of training. Because remember, OTP personnel turnover, just like there are turnovers in other healthcare facilities. So from our perspective, the ATTCs have provided extremely good resources that help guide programs on how to respond, to test, to treat, and then to follow up on how the patient is being cared for. So those are resources that we continually remind our board members and our state chapter members so that they maintain this. And remember, and this will not strike anybody as odd, when COVID-19 had its major impact on our culture, including the OTPs, we had to go through a number of adaptations. And probably one of the most significant adaptations was not so much treating the patient even more holistically, but it was also shifting the paradigm of how we respond to the changing needs of the patient. And in this case, providing greater clinical flexibility in treating the patient is an important component of what's coming out of what we learned from COVID-19. So the ATTCs again become a valuable resource to us, which is why we always work with a number of providers and networks from the history of when we were founded in 1984 to the present. The idea is how we draw partners closer and how we provide better opportunities for the patients that we care for.
Awesome.
Mark,
Thanks so much, Mark. And I know that, go ahead, Nick. You're good? Okay. And I just want to also highlight the fact that, Mark, I believe you mentioned in your introductory presentation that you do often hear requests around billing and insurance reimbursement as it relates to providing various services in opioid treatment program settings. So want to uplift that and name that it's there's a section in the ATC network guide that addresses that, but certainly if folks are, if this is a challenge that you're experiencing, don't hesitate to Mark or our colleagues at ATTC network for additional guidance. I'm going to now, not seeing any additional questions and not seeing any hands up, I'm going to transition things now to Cass to wrap us up.
Yeah, thank you, Adrian. Thank you, Mark, Mike, Nick, and Tina for being on this call and letting everybody know kind of what you do and some of the things that you offer that they might be able to make use of in their own work and their own organizations. Just a reminder to everybody that, you know, this coalition is really focused on drug user health equity for people who use drugs and viral hepatitis care. And so, you know, more topics to come that are related to, you know, how you're able to really center the health of people who use drugs in your work. And we just wanted you to be aware of outside of the TA that we can provide in our learning communities with HepNet. You know, there are other resources that you can avail yourselves of. So as Jasmine mentioned at the beginning, we'll share those just kind of as we continue to get to know each other in this network. But the recording and the slides are going to be circulated next week. So you'll have access to this info to share out with others or to review again. Please also check the chat. I think it was Jasmine who put the evaluation, and you can let us know kind of what you thought about this and what you're looking for future webinars, because we always want to be responsive to your needs and what you're hoping to get out of the network. And then for any questions, please contact either hepatitis@nastad.org or info@nvhr.org. And we'll be sure to address any additional questions or concerns that you weren't able to ask during this chat or about the network more generally.
So with that, I think just another thank you to our presenters. I am going to keep the line open for the next 2 minutes while folks sign off. They can still take the evaluation, but until our next event, stay tuned. Thanks to everybody.